Well, I'd like to just go ahead and start and offer a warm welcome. This is the ATS APSR joint webinar, Global Perspectives on COVID-19. And depending on your time zone, good afternoon or good evening, and welcome to the ATS APSR joint webinar on Global Perspectives. My name is David Lewinson. I'm chair of the American Thoracic Society's International Health Committee, and I'm joined here tonight by my committee vice chair, Dr. Samia Nasser. I would like to thank the Asian Pacific Society of Respirology for their collaboration on tonight's webinar, as well as our distinguished international panel of speakers providing their insight into the COVID-19 pandemic. From the ATS, I would like to give a special thanks to Nicole Allen, Eileen Larson, and Christina Braz, and from APSR, Rina Kishigumi. And before we begin, I'd like to give a few notes and reminders. And if we could go to the second slide. So first of all, we've asked each of the representatives of each region to prepare 10 minutes of remarks to allow time for questions. One, we have muted all of the participants' lines due to the large number of registrants. If you have a question, we encourage you to submit it via the chat feature on the webinar. And we will be developing a frequently asked questions document after the webinar, and our participants have agreed to help facilitate those answers. At the end of the seminar, please complete a brief evaluation at the end to help us identify future topics. And please note that this webinar is being recorded and will be made available to all registrants tomorrow. The archived webinar will also be posted on the ATS website, and feel free to share the link with your colleagues. So if I can have the next slide. Okay, so the aim of tonight's webinar, which we plan to schedule as a series, is to allow respiratory health professionals in different regions to share their experiences with the COVID-19 so far, and have an opportunity to ask their colleagues in other regions questions. This webinar will include practitioners and professors from China, Hong Kong, Singapore, and South Korea. And with that, I'd like to introduce tonight's first speaker, Dr. Wanlin Song. Dr. Song is a professor and researcher at the Department of Pulmonary and Critical Care Medicine, Zhongshan Hospital, Fudan University. He's the chair of the department and associated director of Shanghai Respiratory Research Institute. He is also the elected director of the Shanghai Thoracic Society, and he is head of the APSR Respiratory Infections Non-TB Assembly. So his topic, I'll go ahead and hand this over to Dr. Song.
Hi, thank you, David, for the introduction. I also thank APSR and the ATS for organization of this webinar. So I'm like to share the experience of anti-COVID-19 in Shanghai. Could you upload my slides? Just opening my slides. So here I just want to briefly talk about the Shanghai experience against the COVID-19, the diagnosis and the management. So it's known that COVID-19 has been spreading faster in the past 2 months. So here is the data up to March 19. So I think it's a global issue now. So by the data of March 21st, so far there's around 400 cases have been diagnosed and treated in Shanghai. More than 83% have been cured, and the mortality around 1%. And the majority of the cases recently imported cases, more than 50 now. And the majority of these cases has very mild symptoms. So later I will talk about a little bit in detail. So the diagnostic criteria, for the cases in Shanghai, we follow the guidelines, the national guidelines. This included, the clinical manifestation, epidemiological history, clinical manifestation. So it's a combination of the epidemiology data plus laboratory results plus the clinical symptom. Additionally, the test CT is very important. Sometimes, if some area do not have, the nucleic acid detection assay, the test CT has been set one of the major screening criteria. The confirmed case is suspected case plus the positive detection of nucleic acid either from RT-PCR or from next generation sequencing. So here is some important strategy for suspected cases. We think it's very important, especially at the early beginning of the pandemic. So the clinical suspected case needs to be treated like a confirmed patient, especially in the isolation. Sometimes, there's a false negative result from the nasopharyngeal swab test. So it's a very high positive rate from lower airway secretion samples like the BARF or the lower airway secretion like sputum. So sometimes we find, it's a false negative result from the nasopharyngeal swab test. But if the test CT plus the epidemiology and the clinical data highly suggest the patient could be a COVID-19 patient, we will isolate the patient in our hospital and treat them just like confirmed case. The severity of the illness depends on the oxygen saturation and also some other physiological parameters. So if the test CT scanning shows rapid progress in more than 50% within 24 to 48 hours, and there is a worsening of the oxygenation, at least this three criteria meet one of the criteria, we will classify the patient as a severe phenotype or very severe phenotype. And this patient will be admitted to ICU for the special treatment. We did some of the data analysis for the risk factors for ARDS and for the progression from ARDS to death. And we identified old age neutropenia and organ and coagulation dysfunction, especially in the high ARDS and high D-dimer. They are the very important parameters to indicate the development of the ARDS, also predict the patient mortality. The high fever was associated with a high likelihood of ARDS development, but it's a lower likelihood of death. Some other risk factors for severe COVID-19 pneumonia from the Shanghai treatment plan. So as I said, it's advanced age and a clinical indicator for the deterioration of the COVID-19 pneumonia, comorbidities like hypertension, diabetes, coronary heart disease, obesity, but also progressive worsening of the lung parenchyma, consolidating lymphocytes, decreasing, significantly increase of the serum interleukin-6 levels, and ARDH. Here this shows dynamic changes, especially I think in the D-dimer. Progressive increase in the D-dimer and progressive decreasing of lymphocytes. These are the very important two predictive factors for mortality, for ARDS, also the interleukin-6 levels. In the Wuhan, some of the cases have been treated with interleukin-6 neutralization antibody, but in Shanghai, we only treated one patient. For the treatment of the COVID-19, so we use antiviral drugs, we use the corticosteroid, although it's still controversial. Of course, the support therapy and other treatments like the traditional Chinese medicine. For the antiviral drugs, so far in the Shanghai treatment plan, we focused on the hydroxychloroquine. So we ranked it as the #1 drug in the Shanghai plan. For the lopinavir and ritonavir monotherapy, is the latest China clinical trial. It has been finished and published in England Journal of Medicine by Professor Paul. And in general, it shows a very similar mortality. Now for the Abidol, 200 milligrams 3 times daily for adults, no more for 10 days. And also alpha interferon has been currently used for nebulization in the patient. In alpha or kappa, it's 2 of the nebulization has been used in Shanghai. So here just shows, the New England Journal paper results showed Lopinavir and Rutenavir. It shows very similar mortality when just quantify, the mortality at 28 days, so it's very similar. For the corticosteroid, we have some criteria, for the application. So if the chest imaging shows a rapid progressive changes, the chest radiology, the chest CT or the chest just the regular radiology is a progressive, increase of the infiltration or the worsening of the oxygenation, like the saturation more than less than 93%, respiratory rate more than 30, or the PF ratio less than 300. So for these cases, we use a lower to moderate dose of the steroid. Of course, when the patient receiving steroid, we will think about all the contraindications like diabetes, allergy, uncontrolled hypertension, glaucoma, GI bleeding, all these factors. So if there's no major contradictions, the patient meets the criteria for the rapid progressive of the disease, so we start using the corticosteroid. So here is some of the data we analyzed. This is the 201 patient data analysis. This is from the Wuhan city. So the data in Shanghai is still under analysis. It shows that once the patient developed ARDS and the patient received methylprednisolone, the corticosteroid, it shows a better outcome. It has a reduced mortality. So far, we're still working on the detailed data analysis for around 300 ARDS patients. The majority of patients are still from the Wuhan. In the preliminary data show that some patients have a very good response for corticosteroid, even the lymphocyte is very low. But once they receive corticosteroid, the patient lymphocyte, CD4 lymphocyte, start increasing, and all these patients survived. Here is a situation we use corticosteroid ARDS with high CRP and interleukin-6, severe pneumonia, progressive of the chest infiltration. The dose we used 1 to 2 milligram per kilogram body weight. And also we pay high attention to the CD4 cell count. Every day we check the CD4 cell count after we use the corticosteroid. For the supportive therapy, we use the non-invasive ventilation, use the invasive ventilation, and also the final stage we use ECMO. Also, we use some other strategies like for the cytokine storm prevention, we use a high dose of vitamin C, and we use anticoagulation therapy. If the D-dimer is increased, we use anticoagulation therapy for majority of the patients if there's no major contradictions. Chinese traditional medicine has been used in more than 90% of the patient, especially for the patient with a very mild symptom. So we feel that Chinese medicine has some effect, could prevent the patient developing from mild to moderate and prevent the patient from moderate to severe clinical phenotype. ACEI and ARB, it's very controversial. We do not have a confirmed data whether the patient once developed COVID-19, at the same time the patient hypertension patient. So far we do not have very strong data to support or to use or not use ACEI. So far, if patient still have hypertension, we give the ACEI, we give the ARB. So it's here just very preliminary data. I think it's not conclusive. I think I'll just spend a few minutes to talk about very briefly, the diagnosis and the treatment of COVID-19 in Shanghai. So some of the data, is from the Wuhan city. I have, more than 10 colleagues still working in the Wuhan city. So they shared some data with me, and also we published this analyzed data in JAMA Internal Medicine. And I hope this information will be helpful for the colleagues, for the attendees tonight. Thank you very much.
Thank you very much, Dr. Song, for this presentation. And on behalf of the participants, I'd like to ask you a few questions. The first question is, loss of smell has been reported in the media as an early sign of infection. Is that symptom you've observed? And is there any other unique features that you can tell us?
Yeah, yesterday, I checked with my colleague. She's still working in an isolated hospital in Shanghai. So at the beginning of this COVID-19 in January and February, we do not have too many of the patients, without the losing the sensation for the smelling. But now for the imported case, roughly 10% of these patients complain, so they lose the smell sensation, recently. So I think it's a new feature of the COVID-19, especially for the imported case.
All right. Any other unique features that you can share with us, or?
The patients also complain, the majority of the symptom is fever and dry cough, but also roughly around 5 to 10% complain diarrhea, as in Shanghai, as a GI symptom.
Okay. For physicians in your hospital, did you set age limits for faculty to work with the ICU with the COVID patients? How about pregnant physicians or immune suppressed physicians?
Yeah, since all the patients treated in Shanghai Public Health Hospital, this is isolated. It's a special hospital to treat the COVID-19. So we take care of all the physicians. Everybody who enters into the ICU, into the regular ward, should be fully protected. And the mild patient treated in a different place, and a very severe patient, like the patient that needs the ICU individually, one patient, one ICU, and all the physicians, all these the nurses are fully protected. And so far, so we have 1,700 physicians in Wuhan. So they are the physicians from Shanghai. They went to Wuhan, and also roughly around 50, 60 physicians in Shanghai in the special hospital. None of them got infected. So I think the isolation protection is very important.
That's very good, since in Italy we're having 1 in 10 people, 10 healthcare provider is affected. So that's really good. So have you seen co-infection with the COVID patients with other viral infection like influenza or coronavirus?
Yes, we find the influenza B has been co-infected in some of the patients. Sometimes influenza A and the influenza B, but also some other virus in the RPF, like the rhinovirus and some bacteria. But at a later stage, the bacterial infection is another issue. Roughly around 20%, more than 20%. If they get intubated, more than 20% get bacterial infection.
So how frequent is it that the patients have other viral infections, if you can tell?
Not very high, not very high. So basically, majority of the patients, once when they receive the nasopharyngeal swab test, at the same time, they also receive the test for the influenza A and influenza B. I think it's a very low proportion.
Okay, well, that's good. All right, well, thank you very much, Dr. Song. That was very enlightening and good. Thank you for sharing the information with us. I would like to introduce our next discussion, which is the global perspective of the COVID-19 in Hong Kong. And there will be 3 presenters, Dr. David C.L. Lam, who is currently a clinical associate professor in the Department of Medicine, University of Hong Kong. He is a respiratory physician with a research commitment, translational research and clinical trials. and his research lab focuses on translational research in lung cancer and AIDS and COPD. Sorry. He is currently in the International Lung Screening Trial Consortium steering international lung screening study and biomarker research, and he also is the APSR Secretary General. Next is Professor David Shu Jiang Hui. He is the director of the Stanley Hu Center for Emerging Infections, Infectious Diseases, Jockey Club School of Public Health and Primary Care, Faculty of Medicine, CUHK. He is a chairman of the Department of Medicine and Therapeutics at CUHK and is a Stanley Hu Professor of Respiratory Medicine, Department of Medicine and Therapeutics at CUHK. And lastly, Dr. Men Hu Lee, who is currently president of the CHEST delegation, Hong Kong and Macau. He is a consultant for the Department of Medicine, Queen Elizabeth Hospital, Hong Kong. And he is also honorary clinical associate professor of Li Ka-shing Faculty of Medicine at the University of Hong Kong and the Department of Medicine and Therapeutics, the Chinese University of Hong Kong. So here's the global perspective of COVID-19 in Hong Kong.
Hi, thank you very much for the introduction. And I can see my colleagues, Dr. Lee is on the screen. Actually, Professor Hui is trying hard to ring in, but he said he has a problem in hearing what we are saying from the audio here. So I'm glad that he's actually with us. Without delay, can I start our presentation first? With I would like to take this the few more minutes to show you the COVID-19 situation in Hong Kong. Actually, we have the first case actually imported into Hong Kong when one of the residents in Wuhan in China arrived in Hong Kong, and that first patient was actually referred and managed at the Queen Elizabeth Hospital in Hong Kong. And actually you can see from the graph, indeed, we have been having quite low number of cases confirmed in Hong Kong over the past 2 months until in the recent 1-2 weeks that you can see on the right hand side of the slides, that the cases actually climbed up very quickly in the recent 2 weeks as a result of people returning from overseas. And actually you can see from the numbers we have listed, actually in these 2 days, the numbers of confirmed cases has climbed up to more than 500. And most of them has got travel history. So actually they're bringing in from overseas those cases, and fortunately only 4 of them died, and a significant proportion of them, more than 100, got recovered and discharged, and actually 21 of them were actually ever in critical or serious condition. And interestingly, we have about slightly less than 1/10 of the case being asymptomatic cases. Next, can I have the next slide, please? Yes, we would say over our experience in Hong Kong, we found that these cases have got a short incubation period, but at the same time, they could carry a high viral load. And the cases, the confirmed cases, a lot of them got long virus shedding period. And also we found that there could be rapid person-to-person transmission, and some cases could indeed be asymptomatic or only have very mild symptomatic at the beginning. And over our experience in Hong Kong, we noted that indeed lots of the cases comes from what we call clusters. Initially, we have the cruise cluster from the Diamond Cruise, and then locally we have found some family confirmed cases from family gathering, just like those patients within the same family gathering sharing hot pots. And some clusters were identified from temple attendants that they go to worship and at the weekend and gathered together and then got the diagnosis. And recently we have some clusters coming up that have pub attendance and also the music bands player actually inside the pub. And interestingly, in 2 of the confirmed patients, we also tested their dogs and they were tested positive. Next, please. And the cases that we have seen are mostly mild, and they have very mild respiratory symptoms and fever, and some of them even asymptomatic. And the chest X-ray and CT scans, as you can see from the slides here, initially could be quite clear or very subtle non-specific pneumonic changes. And fortunately, a lot of them recovered quite well. Next, please. So the viral load actually detected in could be detected in asymptomatic patient, and indeed the viral load and shedding of confirmed cases for those asymptomatic ones could be quite similar to those patients who are symptomatic. Next, please. And over here in Hong Kong, we mainly use the triple therapy to treat our patients that consists of the protease inhibitor, lopinavir, and also the ritonavir, together with ribavirin. And we have also tried interferon beta-1 beta if the illness onset is actually before 7 days of the viral shedding. And a randomized controlled trial comparing triple therapy and 2 of the agents inside the triple therapy had been completed. We're waiting for the results locally, and we understand that remdesivir is actually in clinical trial, and we have considered hydroxychloroquine, but it's not in routine use, and probably we believe that it is of immunomodulatory effects, although it's not of a significant antiviral action in itself. Next, please. And so the measures we have adopted in Hong Kong is mainly a containment ones, and what we have done here over the past 2 months is actually tried our best to rapidly isolate the suspected or confirmed cases with quarantine close contact, and we have cancelled mass gathering events over the past 2 months. We have closed all the schools, and we all try to work from home if possible, and we wear surgical masks in a crowded area, plus very importantly, not only mask wearing, but also hand hygiene. And we have also quarantines returnees from overseas, especially the Princess Cruise, the patient, and actually some citizens from entering from mainland China, especially those from the Wuhan province, and also Europe and also North America. Next, please. So from our experience, what we would suggest is that many things could be done at different levels in the society, and especially at the community level or at the society level or the government level. We will try to control and restrict traffic to and from the high incidence area, and we try to rapidly identify and confirm cases, and we have to adopt a very strict containment and quarantine strategy, and to ensure adequate and transparent communications to keep citizens informed of the current situation. We support medical and healthcare professionals and try to support adequate resource allocation to relevant healthcare sectors and their collaborators. And for all the healthcare professional, we advise universal precaution because it's highly infectious, and try to reduce elective clinical procedures as well as admissions to the hospital. And we use appropriate personal protective equipment for patients, especially those who are undergoing aerosol generating procedures like bronchoscopy and also intubation, and also taking nasopharyngeal swabs for the diagnosis. And at personal levels, we stress the importance of using surgical face masks together with proper hand hygiene and practice social distancing, and try to avoid travel and gathering. And at a personal level, very important to seek early medical attention in case of respiratory symptoms and fever. So that's our share of experience at the moment. And Dr. Lee, and I'm not sure if Professor Hui is able to rein in at the moment, but Dr. Lee on the screen and I will be trying help to entertain any questions if there are.
Well, thank you so much. That was a fantastic presentation. And for all of the speakers, there are really amazingly good questions that have been coming up online that I think we'll have to work on providing answers to those in the next few days. So we just had a couple questions. So the first was, and you really went over very nicely your prevention strategies. So we were interested in maybe expanding a little bit more on screening at the hospital. Is it symptom-based? Is it strictly based on contacts? And to what extent have you extended your testing algorithms?
Yes, Dr. Lee, would you like to provide some?
Actually, the testing has been extended. We have now we have a very enhanced laboratory surveillance testing for the case. Apart from those suspect for COVID-19 cases, actually all patients who have community-acquired pneumonia will also be screened. And also if the clinicians have any suspicion, like the patient have unexplained fever, diarrhea, etc., they will also check. So I think we did treasure a lot about the laboratory support of the hospitals in Hong Kong. In fact, they are doing about 4 to 5 rounds of testing per day. So the turnaround time of the results is about 4 to 5 hours, so that we can have the results. I think this is really important for us because for those patients who are put in the isolation facilities, if we can have the results early, then we can discharge those patients. Then so we need a very rapid turnover of the cases in order to save the isolation facilities, because will be at the moment is near our capacity, so we need to be cautiously used. Apart from that, recently we have opened up new testing centers. There are 2 testing centers in near the airport. One is an exhibition center near the airport, another is a relatively small hospital near the airport. So the returnees at the airport, they will go to these 2 centers if they have symptoms. And then they will do the test immediately and then wait for the results at the 2 centers. If they the tests are negative, they can return to their home for home quarantine for the subsequent 2 weeks. I think this is very good because if without these 2 centers, these returnees will be admitted to hospitals because they have returned from overseas and have symptoms. Now they will do the tests in these 2 centers, and then wait for the results. And actually, many of these test negative can go back to their home, and then no need to go to the hospital. So so is I think in a way is also good to us. And also lately many A&E department of the hospital in Hong Kong, they are also doing the tests instead of admitting to the patient, admitting to the medical wards. They do the tests in the A&E department, and then they have they build some of the hospital actually build some tents so that the patient will wait inside the tent for the results. Again, the patient because they are relatively mild symptoms, so they can afford to wait for the result for a few hours in the tent. If the results are negative, they are also allowed to go home and then continue the quarantine practice. Yeah, so I think that can relieve us a lot, because we don't need to be very the isolation facilities will not be too overcrowded. I think the laboratory support to us is very important for us.
Thank you. And maybe on the other end of the spectrum,
sorry,
I know.
David, sorry, David, may I just interrupt? I got a message from Professor David Hui that he is actually online, just although he may not be able to show us the screen at the moment. Can I see if Professor Hui is also online? If he can give us a message, hi, to see if he has any comments and any supplement. Hi, Professor Hui.
I would say yes. I was just seeing if Christina or Nicole, if we can open up his.
Hi, it appears as that he's connected to audio, so I'm not sure what the problem is.
He just messaged me and say he can hear.
Okay.
Is he on mute?
He's not.
Oh.
Let me try to ask him again, but let's proceed on with the question, please.
Okay. So the other question is sort of the other end of the spectrum, which really, I think people are really concerned about the length of stay in our hospitalized patients, in the sense that patients who are no longer in need of critical care may require lengthy treatment and observation, which would take up beds. And we're wondering kind of what your experience and observations have been, and how long patients needed to remain hospitalized.
Yes, we face a similar issue. Even the patient become asymptomatic, the patient still need to keep in isolation because the respiratory sample continue to be PCR positive. So we cannot discharge the patient based on the criteria. So I think we also have this problem, and actually about a third actually have more than 2 weeks or 20 days, etc. They are totally fine, but just wait for the laboratory results criteria to be met. And actually, in Hong Kong, we are looking into this issue, and we are thinking of doing some viral culture. But this is not routinely done, but just for studying whether for those with a very low level of viral load, actually whether the virus are viable or not. So I think we also face this issue. Yeah.
Well, thank you so much. Really. Oh, sorry. Go ahead.
Can I comment? Comment? Young sir. In Korea, for those kind of situation, we have some of the local government have set up what's called community treatment centers. So they would discharge the patient from the hospital and segregate and put the patients in these buildings where they will be kept away from the society until they become negative on PCR. That's how they try to solve the problem.
Thank you. Well, fantastic. And as I mentioned, there are an increasing array of really cool questions coming up. So we'll work on those once we're done. So our next speaker will provide a perspective from Singapore. And this is Dr. Sirhan Phua, and he is currently a respiratory consultant and intensivist in the Tan Tock Seng Hospital in Singapore. He's the program director for the National Health Group. He's respiratory medicine residency program and the acting clinical director for the respiratory therapist services. And he's worked in the intensive care unit and the National Center for Infectious Diseases of Singapore during the outbreak, and is currently part of the outbreak training committee for doctors going into the outbreak ICU. And so his presentation will be on global perspectives on COVID-19, the Singapore experience.
Hi everyone, thanks for this opportunity, and so it is really a good opportunity for me to share what we have experienced so far, and hopefully we can exchange ideas at the end of this. So first of all, I've gotten quite a lot of questions where Singapore is. I just want to show you that it's a really tiny dot just below Malaysia, and it's a small island, but within this island itself we house about 8 government hospitals as it is. And because we are a little hub and we have a lot of international travelers, we actually saw our first patient on the 23rd of January 2020. And as you can see from the graph on the right, it was initially quite a slow rise, but over the last 2 to 3 weeks, you see a very sharp increase to the amount of positive patients that we have received. And this is partially because the government has been actively trying to bring back citizens from all over the world back to Singapore, so that they can treat them as well and contain them within the country. So all these are mainly from travelers, and the numbers are ever increasing as well. So as mentioned, in Singapore itself, we have 8 government hospitals in total. This is not inclusive of all the other private hospitals that are surrounding the island. And the main center that has been packed to deal with the COVID situation is the National Center for Infectious Diseases. This hospital is actually quite new. It was built roughly in 2000, and it was completed building in 2018. And this is linked to the hospital that I'm working in Tan Tock Seng Hospital. So we actually do cross, and we actually help out the wards over there during peacetime. So this hospital can house about 330 beds during peacetime, and it is since expanded to 586 beds. The ICU in the National Center itself can house about 38 beds, but if we were to use the beds in Tan Tock Seng, we can go up to about 90 ICU beds. The whole country can take up about 250 ICU beds in total. I think the challenges so far, is what everybody has been experiencing. We are having issues with resources and manpower. And this is because the doctors and all the staff, the allied health and all, are all kind of locked within their own hospitals. We are not allowed to cross hospitals at all, so that just in case we don't want to infect other people from other hospitals. Of course, bed capacity is always limited. And because of that, what happens is that because of the sharp increase in patients that we are seeing now, the ambulances have been told to be redirected, and all the green and yellow cases, as we label them, have been redirected to the other hospitals as well. So the private hospitals have been quite nice. They have been helping us out, and all the well patients with COVID positive swabs have been sent there to await recovery as well. I guess as an educator point of view, the training of the junior doctors and medical students, took a really big hit. Most of our junior doctors are part of the residency program, and I think a lot of their rotations have been interrupted because of the outbreak situation. And of course, teaching sessions have also been cut down dramatically. We are also going to face an issue with our house because the medical students who are in year 5 now can't sit for their exams. So they are thinking of ways of how to graduate these medical students so that they can join the workforce as house officers or interns middle of the year. I think these are a few of the challenges that we have been facing so far. What are our current state? We actually, as of yesterday, we have a total of 732 positive cases, and out of which 40 have received invasive mechanical ventilation. We thankfully have only had 2 deaths since the start of the outbreak, and these are our mortality rates at 0.3% in totality. But if you were to just look at the amount of patients that come into ICU, it's about 5%, and this is nationwide. At the beginning, up to the end of February, we managed to collect some data prospectively, and we are continuing that prospective data collection. But we have analyzed those data, and just to share with everybody, what we have done is that we have analyzed 60 PCR positive patients, out of which 50 did not come into ICU and 10 got intubated. And just like data all around the world, you can see what's significant is that patients that end up in ICU being intubated tend to be on the older side. Although ours is the median age is about 52, whereas I think what's been published in China is about the age of 65. Tend to be more male predominant, although that's not significant. And why did I put down the ethnicity here is because Singapore is actually a multicultural society where about 75% of them are from the Chinese ethnicity. The other 15% is the Malay ethnicity, and about the remaining 10% is from the Indian ethnicity. Although most of them have some form of comorbidities, but in this analysis, we didn't find any significance between the both of them. I think it's because the numbers are still pretty small here. So the ICU patients, so what we found was that when we actually analyzed the well patients versus the ICU patients, we found that the ICU patients tend to complain of dyspnea a lot more. Their temperatures tend to be higher, and they tend to be tachycardic, more than about 110. The respiratory rate tend to be higher as well, more than 18. And when we look at the blood analysis, interestingly, what we found was that if you have a neutrophil count of more than 4, it really correlates with the need of invasive mechanical ventilation. And this is a direct opposite from what we notice from our well patients. So our well patients tend to be on the lower side. So if you have fever, URTI symptoms, history of travel, and you tend to be COVID positive if your neutrophil count tends to be lower. I think the cutoff number is at 2.6. And just like all around the world, profound lymphopenia is seen with raised LDH. And we did the neutrophil and lymphocyte ratio, it tends to be higher. The LDH and lymphocyte ratio tends to be higher as well. I think what I wanted to highlight is that the CRP levels, the C-reactive protein levels, are raised in patients with, that come in with us that requires invasive mechanical ventilation. We found that a cutoff of 68 had an OROC at 0.92, which is quite indicative. And almost every patient that came to us have some form of infiltrates in the chest X-ray on arrival. So I think some general observations to share. We found that a lot of times that the patients that come into the ICU had profound hypoxemia, and this degree of hypoxemia doesn't really match with the radiological changes. We do see the ground glass changes, which has been widely reported, and occasional basal consolidation. When you do the scans and you analyze the CT scans, they tend to be at the posterior part of the lungs as well. But it just, from the FiO2 requirements and the PEEP requirements that these patients require actually do not really match with the X-ray changes at all. But despite that, the driving pressures tend to be still low, less than 15, and the plateau pressures also usually don't really exceed 30, unless a secondary bacterial infection comes into play. Now, proning works, and proning really helped with the PF ratios. And interestingly, what we have found is some of the patients that recover from ICU, we are reporting that some of them actually experience some autodeoxia, along with some platinumia. So we are submitting this as a manuscript to show some discussion, and we suspect because of the damage on the lungs, there's some pulmonary shunting that's happening, especially when they sit up. So as of yesterday, our invasive mechanical ventilation rates is about 5.5%. But since from the symptom of onset to intubation, the median days is about 8.5 days. A lot of our patients do come in from admission itself and end up in the ICU within a day. And a lot of them is because they come in a very ill state to the emergency department. Prior to that, they probably would have visited 2 to 3 general practitioners or the polyclinics or the doctors just to receive treatment before coming to us. Apache scores and median SOFA scores are pretty similar to the rest of the world, which is about 19 and 8 respectively. The PF ratios prior to intubation is about 104, but post-intubation about 168. About 50% of our ICU patients receive paralysis, and about 20% receive prone ventilation. They tend to be tend to be a single organ. They tend to remain a single organ damage, but later on during their stay, they tend to develop all the other complications. We notice only about 10% of them require CRRT. And if they stay long enough in the ICU, they do get the nosocomial infections. We had one candidemia, a couple of VAPs with Klebsiella. One of our patients actually developed deep vein thrombosis, and one of them actually developed quite significant GI bleed requiring scopes and blood transfusion. I think only 2 so far required ECMO. One of it VV, and the other one required a VA ECMO after a PA arrest. Unfortunately, the VV ECMO passed away, and the one that received the VA ECMO is currently recovering in one of the government hospitals. Out of all the patients that entered the ICU, 3 required tracheostomy, 2 had open tracheostomy in the OT, 1 had a bedside tracheostomy. As mentioned earlier on, we experienced 2 deaths so far. I think just to summarize the ICU perspective in Singapore, we noticed that patients that do require invasive mechanical ventilation tend to have some form of fever, tend to have higher temperatures, tend to be more breathless with raised respiratory rates, tachycardic, poor oxygen saturations. The CRP levels are probably one of the main hints that they may require some form of closer monitoring. Profound lymphopenia with an increase in neutrophil counts, and of course presence of X-ray changes. And again, just to share, the lung mechanics, they tend to have low plateau pressures and low driving pressures despite the high FiO2 and PEEP requirements. And they do respond to prone ventilation really well. And we're actually thinking of prone ventilating patients earlier on. And I know some of my colleagues have actually decided to prone patients when they're not ventilated. And they just require some supplemental oxygen in the wards, and they're already getting them to prone early on. We are yet to see whether that actually really helps. Of course, for the rest of the world, just watch for this photodioxia, because a lot of times this will hamper rehabilitation and physiotherapy post ICU care. And all they need is just some supplemental oxygen and some supine rest, and then the oxygens will actually tend to pick up. With that, I'd like to end my presentation, and I'm happy to answer any questions.
Well, thank you very much, Dr. Phua. And I have a couple of questions, or a little bit more than a couple. So one of them you actually already addressed about the ventilator management. From the management perspective, what's your experience with permissive hypercapnia, proning, and ECMO? If you already addressed it, you don't need to readdress it.
Yeah, see. So I think what we found is that that because prone works really well, that is probably one of the ways that we can actually advise people to avoid ECMO, especially if you do intubate them early and if you prone them early. I think that's one of the reasons why our ECMO rates have been on the lower side. So ECMO, again, our experience is just 2, so it's not that many. And with regards to permissive hypercapnia, a lot of the patients at the beginning suffer from type 1 respiratory failure. But I think towards the later part, when the lungs becomes a lot more fibrotic, that's when the CO2 starts to come up.
Right. Do you have experience with inhaled nitric oxide in these patients' population?
No, and we've not used it, but I think there are a couple of reports that have been out in that just been published and says that I don't think it really did help very much.
Okay. Well, thank you very much, Dr. Phua. We appreciate your presentation. So I would like to introduce our last perspective for this webinar, Professor Soo-ji Young from South Korea. Professor Young is a professor and chair of Division of Pulmonary and Critical Care Medicine of Samsung Medical Center at Sung Kyu Hwan University School of Medicine. Professor Young is the president of the Korean Study Group on Rapid Response System, president of Korean Study Group on ICU Rehabilitation, and vice president of the Korean Society of Critical Care Medicine, and is a fellow of the American College of Critical Care. So Dr. Young, please go ahead.
Hi, actually my name is Dr. Seo, but Ji Young is my first name, and Seo is my last name.
Sorry about that.
No, that's okay. Thank you for the nice introduction. Can you see my slides?
Yes.
Yes.
Oh, good. Okay. I will talk on the South Korean experience. Actually, our experience began quite early, as our first patient was diagnosed while entering Korea. She was a Chinese national. She was entering the airport, and she was diagnosed at the checkpoint at the airport on January 20th. Then we had a couple of cases, mostly from China. Then there was a big increase in mid to end of February, as you can see. Now the cases seems to be leveling, and this is the number of patients by day. As you can see, it went up to close to 1,900, over 900 patients. Then we are leveling at about hovering around 100 patients per day these days. Sometimes a little bit less, sometimes a little bit more. But these a lot of cases was from the one religious cult sect called Shincheonji, and around 60% of our cases are related to this religious sect. And many of the patients are concentrated in one area. So around 80% of the cases are from the Daegu and Gyeongbuk area, and in other areas are not that contributing much to the number of patients. But we are not out of the woods yet. As you can see, for Seoul and surrounding Gyeonggi area, the number of patients are slowly accumulating. As you can see, there's no bending of the curve yet. So we are still in a high alert mode in Korea. So why was Korea relatively successful in containing the virus so far while avoiding total shutdown of the society? I think one of the experience that helped was the experience in 2015 that we had with Middle East respiratory syndrome epidemic. For the general public, there was a widespread awareness of dangers of coronavirus infection. For healthcare centers, it was a very good moment to make those protocols about this kind of epidemics. So before 2015, none of the hospitals had any protocols for this kind of things. But after 2015, most had protocols already set up for isolation of suspected patients and testing. And for government agencies, there was, after the 2015, there's improved communication on this kind of stuff, improved manpower, and the people who are leading the fight against the virus currently had a very first-hand experience in 2015, so that also helped. Also, we use a lot of technology in tracing contacts, tracking visitors, and notifying healthcare workers about heightened risk. For example, we would use surveillance cameras and GPS data of phones, and we would send out text messages of confirmed patients' whereabouts to the citizens who live near that area. And we, for visitors coming into the country, they have to download application for smartphones, so the government can check their health and their whereabouts of them. And we have one insurance system, which is the government in our country, one insurance, and they have this system called drug utilization review system, where we can check what drugs the patient was on before they came into our hospital. But the government, after this episode, decided to include travel history in the review system. So when a patient comes in to our hospital, we can check where he has been in for example, if he'd been traveling to Italy or US or China, we'll be very on high alert. Also, we were very successful in minimizing spread from asymptomatic or minimally symptomatic patients. Excuse me? Okay. So because we had very aggressive early testing of contacts and at-risk population, even if they were asymptomatic. And there's a universal wearing of face masks. I think one of the panels alluded to earlier, I think that was really helpful in containing the spread from these asymptomatic patients. This is the entrance of our hospital, Samsung Medical Center. Everyone who comes into the hospital has their body temperature checked and their travel history checked, and asks if they have respiratory symptoms. And if they have respiratory symptoms or suspect been near these travel history, they will be not allowed to enter the hospital and would go to a screening center to be tested for coronavirus. This is our ER. So when a patient comes into the ER, we would triage him in a separate building in front of the ER. And if it's a suspect of a coronavirus, he would go to, if it's not suspected, he would come into the ER. But if it's suspected, he would go to this isolation rooms to be examined and be tested. This is the entrance, and there's a relative pressure rooms in there. And this is the facility of the room. And also, we clear the parking space where we would set up a screening center for people to get tested. If they have symptoms or they have a fever, the hospital will send them to here to get tested before they can come into the hospital. This is the drug utilization review system of government insurance agency, and this is our EMR, the picture of our EMR, and if we click here, the pop-up, there will be a pop-up screen to tell us if he's been traveling. We have from early on, we had a very big capacity for testing, and at the peak level, we tested around 20,000 tests per day as a nation. And you can see the positive rates were very low. At most, it was around 3 or 4%, I think. We were very innovative in testing. As you can see, it's one of the drive-through testing centers. I think some US centers have this kind of setup, but we were the first country to have this kind of testing system, which minimized contact between the testee and the testers. Also, now we have what's called walk-through testing centers. This is a testing center at the airport where people who come from the Europe area have to go through mandatory testing and get a confirmed negative result before they can leave a facility. Also, I think the mask, Koreans are very, very conscientious about wearing masks as a society. And I think although there's no evidence that it protects, but there's an essential distinction between absence of evidence and evidence of absence. And since COVID-19 could be transmitted before symptom onset, community transmission might be reduced if everyone, including people who have been infected but are asymptomatic and contagious, wear masks. And this comment on the Lancet illustrate to the opinion of the Oxford group, but I think this really helped to contain the spread of the virus. Many challenges are there. One is the separating COVID-19 patients from other patients. We did this with early aggressive testing. And we had in my hospital, there was a regular meeting of those people involved in care. So we set up approaches for how to handle people who have fever or respiratory symptoms but need urgent care. For example, if a patient needs a cesarean section for delivery and she has a fever, how would handle that? We have all the protocols set up for those things. And we have separate rooms put aside for suspected patients. Pathways for common procedures were carefully thought out before. Also, the handling of fear among medical people, doctors and nurses, can be very difficult sometimes. So we have to educate about them and educate them on donning and doffing of personal protection equipment. And there's problems of triage of people who needs close observation from those who may not need those close observations. And in early phase of our outbreak, some of the people died while awaiting to get admitted to the hospital. And to avoid those kind of tragedy, if you have a big surge in patient numbers, you have to think through how to separate those people with very low risk of bad outcome and people who has a high risk of a bad outcome. And as I alluded to before, some of the local governments have put on the so-called community treatment centers. Some use them to house low-risk patients from the beginning, and some use it as people who are discharged and very well, but they're still positive PCR to house them. So I think early detection is the key for community to reduce spread from people with no or mild symptoms, for hospitals to reduce spread to healthcare workers and other vulnerable patients. And triage system is, you have to think through that. And for people who are admitted, you close observation of people who start to desaturate. And you should have pathways thought out so that critically ill patients who do not have coronavirus does not suffer. Thank you for your attention.
Thank you very much.
Thank you. Sorry, I was on mute. 1 second. Well, that was really a fantastic perspective. I think we have 2 questions, and then we can wrap up from there. So the first question was, and you touched on this already, but practical strategies for preparing the medical center for a surge. And for example, stopping all elective procedures, proactively reducing ICU capacity, sort of how did you think about a potential surge?
Actually, my hospital is in Seoul area, so we didn't have that surge of patients that people at Daegu area had. But I think we have to cancel the elective patients and discharge patients who are minimally ill, so we can save beds for the COVID patients. And also maybe prepare the ICUs so that we can ventilate as many people as we can, and also educate our healthcare workers on the personal protective equipment, and I think that's the key.
And then one final question, and certainly this might be for all of you, is sort of how do you recommend supporting physicians at your medical center? Have you done shorter shifts? And what kind of strategies have you employed to reduce burnout and fear, I think, as you had mentioned?
For us, the number of patients that we had so far in our facility is only around 6 during the whole time. So we would give them many extra things. For example, we would give them food, a place to stay in the hospital where they can rest, because there were some of the personnel don't want to go home because they think they might infect their loved ones. So we would provide a place to stay for them and provide them food. And after they are finished working with the COVID-19 positive patient, we give them 1 week off, paid free time. But because that's possible because we didn't have that many patients so far. But if we have that, we might need to recruit more ward nurses to work in our ICUs, and doctors who are not really who does not work in the ICUs regularly. We might have to educate them and bring them into the care also. But fortunately, we have not been in that situation so far in our hospital.
Well, we're a little bit over, but I really appreciate everybody's comments, and really on behalf of the participants, the ATS, the APSR, I would like to thank all of tonight's presenters for their perspectives, recommendations, and strategies. And I want to thank our participants for submitting what I think is an amazing array of questions, super interesting. We will work hard to perhaps collate those questions and get responses from our presenters. And a quick reminder to our participants to complete the evaluation so that we can identify future topics and continue to improve our series. And finally, I invite all of you to join us for future presentations of this webinar. I wish you all health and safety during this COVID-19 pandemic. And I think mine and Samia's thoughts are with you all. And thank you very much.
Thank you very much.
Thank you.
That was very good.
Thank you.
Thank you.
Thank you.
Bye.